Putting it all together. For centuries, scoliosis has been a riddle. Physicians, parents, and patients have asked the same questions. Why does it happen? Will it get worse? Can we fix it? For most of medical history, those questions were answered more with guesswork than science. Ancient Greek physicians, such as Hippocrates, described spines twisting like a serpent, and tried crude traction methods to straighten them. In the Middle Ages, healers strapped people into cumbersome devices that pulled and pressed the body in hopes of forcing it into alignment. By the 20th century, the focus was still entirely mechanical. Rigid plaster casts, thick plastic braces, and surgical rods of stainless steel or titanium meant to lock the spine into place. The backbone was viewed much like a warped wooden beam. The problem was its curve, and the solution was to straighten it by force. But with time and careful observation, cracks began to appear in this bones-only way of thinking. Doctors saw patients with very large curves who managed to live long, productive lives without ever being treated. They saw others with relatively small curves whose spines deteriorated quickly and unpredictably. Pain was present in some cases and absent in others, with no clear pattern. In short, the severity of the curve on an X-ray didn't always predict the quality of life, the likelihood of progression, or the eventual outcome. Something deeper was influencing the spine's shape and behavior, something happening inside the body's systems, not just in its structure. In the past 2 decades, a series of influential studies has reshaped how the medical community thinks about scoliosis. They have come from orthopedic surgery, chiropractic rehabilitation, genetics, neuroscience, and nutritional science. Although they approach scoliosis from different angles, they all share one theme. Scoliosis is not just a static bend in the backbone. It is the visible end result of a complex interplay of genetic predisposition, brain and nerve chemistry, growth patterns, muscle coordination, and even nutritional status. By pulling together findings from long-term patient follow-up, targeted rehabilitation, surgical outcome reviews, genetic mapping, neurotransmitter analysis, and nutritional supplementation, these studies have moved the field toward a more nuanced and personalized model of care. One of the most eye-opening pieces of research began not in a modern laboratory, but in the middle of the 20th century, when braces and spinal surgeries were not yet widely available. Physicians at that time decided to track patients with idiopathic scoliosis, curves with no known cause, who received no treatment at all. They examined these individuals decades later, when they were between 54 and 80 years old, to see how they were functioning in their daily lives. Many in the medical community expected to find widespread disability, severe breathing problems, and shortened lifespans. Instead, the results were far more hopeful. Most of these patients were still alive, active, and independent. While they were more likely to report back pain than people without scoliosis, most described it as mild or moderate rather than severe. Only those with very large thoracic curves, over 80 degrees, showed a clear link to breathing difficulties. This long-term natural history study challenged the assumption that scoliosis was always a looming threat, requiring aggressive intervention. It gave doctors and families permission to think more strategically about who needed immediate treatment and who could be monitored safely without rushing into major procedures. While that historical study revealed what could happen when scoliosis was simply left alone, modern rehabilitation specialists began to test what could happen when targeted, non-surgical interventions were applied, even after the traditional window of opportunity had closed. For decades, it was widely believed that once a teenager stopped growing, their scoliosis became fixed, immune to meaningful improvement from exercise or therapy. But a group of chiropractors and rehabilitation experts decided to put that belief to the test. They developed a program of scoliosis-specific exercises combining core muscle strengthening, spinal flexibility training, balance drills, and postural corrections. Patients came for intensive clinical sessions and then continued structured exercises at home. When these teens reached skeletal maturity, more than half had improved their curve measurements by an average of over 12 degrees, a change large enough to be visible on an X-ray and in posture. Nearly 4 in 10 held their curves stable, while only a small fraction worsened or dropped out. The message was clear. The spine remains adaptable, even after growth stops, if it is given the right kind of targeted, consistent stimulation. In the surgical realm, another set of researchers examined what happens many years after spinal fusion, the most common operation for large curves. The immediate results of fusion are often dramatic. Surgeons can reduce a curve by 40 to 60% in a single procedure. But the long-term picture is more complicated. Following patients for 5 to 20 years after surgery, investigators found that while the operation usually stopped curve progression and improved appearance, it did not always eliminate pain or guarantee superior function compared to those who avoided surgery. Some patients experienced hardware failure, wear and tear on spinal segments adjacent to the fused area, or needed revision surgeries. For a few, the trade-offs were significant enough that they questioned their original decision. These findings did not argue against surgery outright. Fusion remains a valuable option for certain high-risk curves, but they reinforce the need for individualized decisions and honest discussions about both the benefits and the potential long-term costs. While orthopedic teams were tracking physical outcomes, geneticists were probing the molecular blueprint. One groundbreaking genetic study took a broad view, examining not a single scoliosis gene, but patterns of functional genomic variants, small changes in DNA that influence how biological systems operate. By comparing Caucasian adolescents with idiopathic scoliosis to healthy peers, researchers identified 19 functional variant groups that were significantly more common in the scoliosis group. These variant clusters touched on systems such as hormone regulation, bone metabolism, muscle tone, and nerve signaling. The teens with the most severe curves often carried more of these variant groups than those with milder curves. This supported the idea that scoliosis results from the combined influence of multiple small genetic differences that together alter the body's growth and control systems in ways that make spinal curvature more likely. Around the same time, neuroscientists began exploring the role of the brain's chemical messengers, neurotransmitters, in scoliosis. In one controlled study, adolescents with idiopathic scoliosis were found to have consistently lower serotonin and histamine levels and higher norepinephrine levels compared to peers without scoliosis. These chemicals influence muscle tone, reflex timing, balance control, and the coordination between right and left sides of the body. An imbalance could subtly alter how postural muscles activate and respond to gravity, potentially leading to the asymmetrical forces that encourage a curve to develop or worsen. The implication was that scoliosis might partly stem from how the central nervous system regulates posture, not just from abnormalities in the bones and muscles themselves. Further refining the genetic picture, another study zoomed in on 2 specific genes, COMT, which helps break down neurotransmitters like dopamine and norepinephrine, and MTHFR, which is crucial for processing folate into forms the body can use for DNA repair, cell division, and neurotransmitter synthesis. Variants that reduce the efficiency of these enzymes could influence both brain chemistry and tissue growth. When researchers divided scoliosis patients into groups based on whether they carried low-activity versions of both genes, the difference was striking. Nearly 80% of those with both low-functioning genes experienced significant curve progression before skeletal maturity, compared to less than half of those with one or both genes functioning at a normal level. This finding pointed to a potential future in which genetic screening could help identify high-risk patients early, allowing for preventive measures before the curve advanced. In yet another dimension, researchers investigated whether correcting certain nutrient deficiencies could influence scoliosis progression. Melatonin, best known as a sleep-regulating hormone, also participates in bone formation and muscle repair. Vitamin D is critical for calcium absorption, and calcium itself is the basic building block of bone. In a randomized trial of children and teens with newly diagnosed scoliosis, many were found to have low levels of one or more of these nutrients at baseline. Over the course of a year, those given daily supplements of melatonin, vitamin D, and calcium showed less curve progression than those who received no supplementation. While the results were preliminary and the sample size modest, the study suggested that supporting bone and muscle health at the biochemical level could be a simple, low-risk way to help stabilize certain cases, particularly when deficiencies are present. Taken together, these diverse lines of research dismantle the old image of scoliosis as merely a static mechanical defect to be braced or bolted straight. The long-term natural history data show that many people live well without aggressive intervention, but also help pinpoint which cases, such as very large thoracic curves, are more likely to cause functional problems. The rehabilitation findings prove that targeted, scoliosis-specific exercise can change spinal alignment and stability, even after growth is complete. Surgical outcome studies remind us that fusion is a tool, not a magic fix, and that its long-term value must be weighed against its potential downsides. The genetic studies reveal that scoliosis often rides on a web of small, function-altering DNA changes, some of which can interact to dramatically raise risk. The neurotransmitter research connects the condition to how the brain and nervous system control posture and balance. The nutrient supplementation trial adds a practical, accessible layer to management, addressing biological weaknesses that could make the spine more vulnerable. This shift in perspective moves scoliosis care toward personalized medicine. Instead of making treatment decisions based solely on the size of the curve at diagnosis, clinicians can now consider a broader profile: genetic predispositions, neurochemical patterns, nutritional status, growth stage, and the patient's own functional goals. A teenager with a moderate curve but a high-risk genetic pattern, low serotonin, and nutrient deficiencies might be counseled toward early, multi-pronged intervention: targeted exercises, nutritional correction, close monitoring, and perhaps bracing. Another teen with a similar sized curve but a low-risk genetic and biochemical profile might safely choose a more conservative watch-and-wait approach. In everyday terms, the message from these studies is both reassuring and empowering. Reassuring because scoliosis is not inevitably a march toward disability. Many people live long, active, and fulfilling lives with it, sometimes without major interventions. Empowering because there are now more tools and more knowledge to match the right treatments to the right patient at the right time. The game changers in scoliosis research have not provided a single universal cure. Instead, they have revealed scoliosis as a condition with many possible pathways, each influenced by the body's unique biology and environment. And with that understanding comes the opportunity to guide those pathways toward better outcomes.